We'll come back to the second video of fluid management in post-operative patient, and today we're going to talk about volume resuscitation. That means these patients still having abnormal fluid losses, right? And as I said, this could be they are losing blood, third spacing, right? Or drain output, high drain output. This is on top of being NPO, of course, sometimes. Okay. So the first thing, as I said, most of these patients, when they come back to the floor from the PACU, from the OR, they are already on IV fluid by the surgeon most of the time, right? So the first thing here is to assess is hemodynamic stability, which give us really a direct evidence of is there an adequate perfusion or not of the organ. And hemodynamic stability, of course, we're looking at the vital signs. An adequate perfusion on top of the vital signs, we look for lactic acid level and urine output. So that's why it's very important to monitor the vital signs, lactic acid level, urine output, because give you an idea of adequate perfusions. If the patient post-operatively became hemodynamically unstable, you call the surgeon immediately and you resuscitate, as we talked, with an isotonic, with 2 to 3 liters of isotonic solution. Of course, here we're talking about normal saline or LR or plasmalite, which is not that available because it's expensive. So we mainly think about lactated ringer or normal saline. And we said surgery, they like lactated ringer. So most patients in post-operative period, they receive lactated ringer by surgeon. But I'll talk about special cases where we prefer one over another, but 2 to 3 liters, right? And the first thing I think about somebody hemodynamically unstable after surgery is blood loss. Are they bleeding? Of course, the surgeon will help guide what we're going to do is they're going to take back to the OR. So, but as an internist, inform the surgeon, try to stabilize them, you give them fluid. If you suspect there is a blood loss, you give blood transfusion, right? That's very important. Now, is there cases where I need to give normal saline instead of LR? Of course. Let me give you a quick example. Vomiting. Vomiting, as you know, can cause contraction alkalosis. So NS would make big sense because NS can cause that hyperchloremic metabolic acidosis and can counteract that, right? So that's one thing. If the patient is receiving blood transfusion and you need to give fluid, NS to go. Because you want to avoid, while you're giving concomitant blood transfusion, you want to avoid giving potassium, calcium, citrate, all of that. So NS is really the way to go. Okay? In head trauma or neurosurgery, they prefer NS because they feel NS will likely to induce hypernatremia more compared to LR or plasmalite, because in neurosurgery they like the sodium to be normal or on the high side, and they want to for sure avoid any kind of hyponatremia. Brain cells are very sensitive to hyponatremia, they can swells pretty quickly, right? So also in cases of hyperkalemia, normal saline is the best to go because it doesn't have any potassium, right? And if in case if you have AKI and you're concerned about the potassium in LR or plasmalite, you give NS. Remember, we talked about that the potassium in LR or plasmalite is very limited, but if you have an option not to give any potassium because any concerns, then you go for normal saline. In other cases, especially when there is significant loss of sodium bicarb, right, then bicarb drip is the way to go. especially with GI losses, right? Like pancreatic fistula or some kind or diarrhea that you lose a lot of bicarb then and you develop acidosis, then bicarb drip is the way to go. And we talked how we mix bicarb drip and how to give it, right? So these are the main things. Now, the patient may be hemodynamically stable, but he's having ongoing losses with a lot of drains, third spacing. So you want to avoid to get to this point. So you want to replace these abnormal losses. So some people count how much you lose in the drain and then replace it back. So that's one approach. And some people just put on an IV fluid at specific rate and just monitor signs of perfusion. And I've seen both. So some people they just give, let's say, NS or LR at 125, for example, mil per hour. Especially if there's a third spacing you feel into the abdominal cavity. And then you monitor the hemodynamic stability and signs of perfusion, and you decide. And you keep this until this becomes really minimal and there is no more or minimal ongoing loss, that the patient can replace them orally once the patient starts eating. Remember on all of this to keep monitoring electrolytes, sodium, potassium every day, if not even more frequent, to catch any hyponatremia, hypernatremia, hypokalemia, or hyperkalemia very early and treat it. I'll see you next time. Thanks for watching this video. Please subscribe to our channel and activate the notification bell so you get to see the videos as soon as they are released. Glad to have you on board.